Hi, Dr. Becca here with Del Mar Center for Behavioral Health with another short video. Today I'm going to talk a little bit about what is autism or what is autism spectrum disorder. In 2013, our new DSM or Diagnostic and Statistical Manual of Mental Disorders, often called the DSM-5, was released, and that is what we use in clinical psychology to diagnose different mental health conditions. And in 2013, the DSM-5 was released, which is when the language changed from autism or autistic disorder to autism spectrum disorder. And this definitely caused some confusion for people, and understandably so, because there used to be Asperger's and PDD-NOS, which stood for Pervasive Developmental Disability Not Otherwise Specified. And all of these labels were subsumed or came under ASD, or Autism Spectrum Disorder, under the new DSM-5. And so what exactly is autism, right? Sometimes we've seen different characters on TV, or we've seen maybe one person with ASD, and then we see another person, and we think, how can those be the exact same diagnosis? It looks so different. And I would agree. I think that is where the quote, I forget who said it, but if you know one person with autism, you know one person with autism. And I think that really speaks to the idea that it is a spectrum and it looks different in different people. There's different severity levels, different skill deficits, different behavioral excesses, and so it really can look different across individuals. So according to the DSM, there are a couple different criteria that must be met in order for the diagnosis of ASD, or autism spectrum disorder, to be given. And one of those is a deficit in social emotional reciprocity, right? And that really means reciprocity is the back and forth, or that interaction. And it means that there may be a failure to initiate or respond, or failing to interact with others, but it isn't just that. It also is that they may do so or may try to interact in a poor quality. So it isn't always just a lack of interaction. Sometimes it's of a poor quality than what would be expected given their age. There's also deficits in nonverbal communication, and this is important because while it's easier to pick up on when there's a vocal verbal or a expressive language deficit, we know from research that anywhere between 80 to 90% of our communication is nonverbal. So if we are not picking up those nonverbal cues in others, and that's how 70 to 80% of information is being communicated, we're really missing out on a ton of information. And so it's not only misreading those cues in others, or completely missing out on or missing those cues in others people. It's also that when the individual uses those nonverbal communicative behaviors, that they're often not integrated with verbal speech, right? So as I'm saying yes, I'm nodding, but I don't just nod I don't nod and say no, right? That's not integrated. Or I don't walk around nodding my head when somebody hasn't asked me a yes or no question. Right, and so that's an example of that lack of communication. There also is deficit in developing and understanding relationships. And so again, that can be having a difficult time adjusting. It can be having no interest in those relationships, or not understanding that certain relationships are a certain way, right? I act a certain way with friends, but I act a different way around teachers, almost like code switching. And all of these sort of examples fall under deficits in social communication, right? We talked about those three different components of social communication, that back and forth or reciprocity, along with the nonverbal communication, and then difficulty in establishing relationships. The other part, or the other criteria that's important or necessary really when making an ASD diagnosis, is there has to be restricted and repetitive patterns of behavior, interests, or activities. And so that is the idea that there are stereotyped or repetitive motor movements. A lot of times people think about hand flapping or rocking, right? So those are examples of repetitive movements. Stereotypy could be vocal sounds, or even holding items and then looking in a peripheral eye gaze. A lot of our little guys do that. Another component of that restricted and repetitive patterns of behavior and interest is also a need for sameness and really an inflexible adherence to routine. So the idea that when the schedule changes or something is new or different, it is really difficult for people with ASD to adjust to that, or to manage the discomfort that comes along with that change. There also can be highly restricted, or what's often called fixated, areas of interest. And so it isn't just that somebody is really stoked about something, it's that they like one thing to the exclusion of others. And so common areas that come up are letters, numbers, space, trains or cars, sort of the way things work. And kids and adults will be fixated on these things to the point that they're not interested in other things. There's also hyper or hypo sensory input. And so that can be, hypo means they're seeking, right? Sensory seeking, it's often called. These kids might like spicy or crunchy foods, or crash into things, or hypersensitive to sensory stimuli, which might mean that they probably cover their ears, right, when it's loud, or bright lights bother them, and they are overreactive to certain sensory stimuli. And again, these examples all fall under the criteria of restricted and repetitive patterns of behavior or interests. Also part of the DSM-5 description of ASD is that the clinicians, we have to specify whether there is also an impairment in language that is accompanying this diagnosis, and also to specify if there is an accompanying intellectual disability. We can do a whole other video on what an intellectual disability is, but it's essentially an IQ score of less than 70, and it's important for that to be included in the diagnosis. Symptoms also must be present early in the developmental period. So it isn't that somebody is fine and then all of a sudden at 12 these behaviors show up. Typically there is a long period starting in early childhood of some of these behaviors. That doesn't mean that they're as impairing as they are as they get older, right? Because when kids are younger, they don't have as many skills. So if in order to identify deficits, there has to be enough skill difference between them and their peers to be able to pick up on it during testing. The symptoms also have to cause impairment in social, occupational, or other important areas of functioning. And that means that some kids are quirky, but that doesn't mean that they have ASD. Or some of us like things in the same order or routine, but that doesn't mean that it's ASD. It's only a mental health or a mental disorder meeting the criteria to be autism spectrum disorder if it's causing distress or impairments in areas of the individual's life. And then again, with the new DSM, we have to identify whether there is an accompanying intellectual impairment, which refers to cognitive scores or IQ scores, and we also have to identify if there's an accompanying language impairment. So again, this was a brief review of the diagnostic criteria for autism spectrum disorder, or ASD as it's often called, according to the DSM-5, which since 2013 has been what's used to make the diagnosis of ASD. Before that, there were other labels such as autistic disorder, Asperger's, PDD, NOS. And so with the change in criteria, most individuals have had an updated testing to determine if they still meet criteria for ASD. Thanks for taking some time to tune in with me, Dr. Becca, here at Del Mar Center for Behavioral Health. I look forward to seeing you guys soon. Hope you have a great rest of your day. See you later.